Good morning, everyone. Thank you very much for the kind introduction, and thank you very much for the invitation. And I have to say that after the invitation, I had the opportunity to go over the library. It's a really impressive library of lectures about hepatology, and I feel privileged to be part of that. Thank you, everybody that is connecting in real time, too. So my task today, these are my disclosures in the last 2 years. And my task today will be to review the management of refractory ascites. And this is what I'm going to talk about. When is ascites refractory? And I will give some notes on medical therapy. And I will discuss advanced management, mainly with tips versus paracentesis and the role of indwelling catheters. And in the discussion, the lecture will be approximately, I was asked to talk to 45 to 50 minutes, and then I'm happy to discuss any other topic. So I would like to start by giving some pathophysiological notes to understand the treatment of refractory ascites. And this is very simplified, what happens hemodynamically with the progression of cirrhosis, that there is a progressive decrease in systemic vascular resistance due to splenic vasodilation, because splenic vascular bed is 30% of the accounts for 30% of the systemic vascular resistance. So when there is vasodilation, there is a compensatory increase in cardiac output. And initially, mean arterial pressure is maintained thanks to this increase in cardiac output, but at some point, cardiac output cannot compensate, and you start to have a decrease in mean arterial pressure. So probably ascites starts to happen here around this when the hemodynamic abnormalities are severe enough. But then when you start to see that decrease in mean arterial pressure means that the circulatory dysfunction is severe, and this is when we see refractory ascites, hyponatremia, and hepatorenal syndrome. So at this stage, you can imagine that anything that happens to the patient with this extreme vasodilation, with a cardiac output that has been maximized, makes the patient extremely vulnerable to have a decrease in renal perfusion. There might be dips in this natural history. For example, if you have a bleeding, you have hypovolemia that decreases the cardiac output. Beta blockers has been a consideration. If blockers cause hypotension, probably we are in an unsafe area, and there might be infections or the use of pharmacological vasodilators that might worsen the hemodynamics. So the first question I want to address is if ascites is refractory. This is very important because therapeutic paracentesis uses a huge amount of resources. We many times have problems to get these patients into our outpatient unit, so the patients end up in emerge. So therapeutic paracentesis is a precious resource. So we have to be sure that ascites is refractory. And there is no question that ascites is refractory where it cannot be mobilized or its early recurrence cannot be prevented. These are AASLD definitions. And if diuretic resistance, they do not respond to maximal doses of diuretics, which is spironolactone 400, furosemide 160. Other potassium-sparing agents are much less effective, like amiloride. And the most controversial issue is when ascites is intractable, when there are complications of diuretics that preclude the treatment of ascites. And the first thing I want to address is when there is renal impairment, because I want to emphasize that when you give diuretics, most of the times to patients with ascites, most of the times there is an increase in creatinine. And but what defines diuretic intractable ascites, according to AASLD, is an increase in serum creatinine by 100% or to a value or above 2 milligrams per deciliter. And with this definition, many patients will have AKI before we decide to stop the diuretics. And for quite a long time, we were told that these episodes of AKI or increasing creatinine that we cause with diuretics in patients with ascites, this could lead to chronic kidney injury. And so that was a reason that if you have a patient with ascites, you put them on diuretics and there is an increase in creatinine, you stop the diuretics, you classify the patients as with refractory ascites, and you start paracentesis. And I think there are many patients that will have the opportunity to have ascites well controlled to diuretics that for this reason are not treated with diuretics. And I thought it was very interesting when I found this paper that was published in Annals of Internal Medicine in 2003 that evaluated very carefully the impact of these episodes of mild AKI or moderate AKI on the trajectory of the kidney function. And I put directly the conclusion that after pre-AKI, EGFR, proteinuria, and all the covariables were accounted for, the association between mild to moderate AKI and worsening subsequent kidney function in patients with chronic kidney disease was small. So I think we have to have less fear to those minor increases in creatinine that we cause with diuretics in ascites, and probably we will have less need for paracentesis in our unit. Hyponatremia is also important. It's frequent to cause hyponatremia with diuretics. A decrease of more 10 millimoles or an absolute value of 125 should tell us that we are giving probably too much diuretics or we are causing complications. But you see this threshold is 125. It's not 130 or 128. It has to be a severe hyponatremia. And hyperkalemia, again, with quite flexible limits. So very important to not give up on diuretics too early. Another and hepatic encephalopathy is also maybe trigger. Hypovolemia is a strong trigger for hepatic encephalopathy because they start to generate ammonia very quickly. So it's another concept that is very important that is also highlighted in the AASLD guidelines, which is ascites that recurs on at least 3 occasions within a 12-month period, despite dietary restriction and adequate diuretic dose. And this is important because it defines further compensation according to Baveno consensus criteria. And then when we discuss tips, we will see it has been used as a criteria to indicate the tips. The last part of, when ascites is refractory, many times we have to look at what the patient is taking because many times a diuretic intractable ascites is the result of the use of concomitant medications. There is no question, everybody knows that NSAIDs should not be used in patients with ascites. There is this small study because there are patients that, for whatever reason, they need NSAIDs, that suggesting that celecoxib was safe in patients with ascites, but it was a small study just for 3 days. So if I need to give NSAIDs for a short period of time, I use celecoxib. ACE inhibitors and angiotensin receptor antagonists and in general any vasodilators like calcium antagonist, most of the time be discontinued in patients with ascites. And again, that might transform a diuretic intractable ascites into an ascites that responds. And this is very important because with a shift in etiologies, we didn't really have patients before 20 years ago on these medications, but now most of our patients are NAFLD-related cirrhosis, and many of them are or were being treated with these medications. But really, when we get them, when they get ascites, the blood pressure already has decreased. There might be some very specific circumstances like patients with proteinuria that might need these medications. But we showed, us and others many years ago, 23 years ago, a long time ago, that in patients with child B, so in patients decompensated, when they got losartan, there was a substantial decrease in GFR that was associated with a substantial decrease in mean arterial pressure. In compensated patients, there was no problem at all in giving angiotensin receptor blockers or ACE inhibitors. So a very important concept, I think. statins, very hot topic, whether we should statins to treat cirrhosis, but it's important to know that atorvastatin metabolism is markedly abnormal in child B patients. The systemic exposure to atorvastatin multiplies by 11. And simvastatin, we have had a few trials, including the latest Live Hope trial that was presented in EASL last year, that showed that even with simvastatin 20, which is a low dose, there is a substantial risk of rhabdomyolysis. Rosuvastatin has minimally abnormal pharmacokinetics in patients with cirrhosis and should probably be the choice if we need to treat these patients with a statin. And beta blockers, again, another controversial issue that will require long explanations, but my summary is that blockers cause kidney problems when they cause hypotension. If they don't cause hypotension, they hardly ever cause kidney problems. And a study from Shiv Sharing in India showed that treating with carvedilol, even patients with ACLF, might improve the prognosis and is not associated with AKI. And in these patients, maybe that have some degree of heart failure, maybe treating them with carvedilol might be good for the kidney. If hyponatremia, it's important to consider discontinuation of SSRIs or looking for an alternative because they can cause hyponatremia, and that make it very difficult, the treatment with diuretics. I think these are a few tips that can transform diuretic intractable ascites into a treatable ascites. Again, the goal is to minimize the patients in which we need to jump into paracentesis. I want to give a few notes about potential new trends in medical therapy, like albumin. There is a great video about albumin in the library, so I will not extend myself. The potential FGLT2 inhibitors and the use of continuous vasoconstriction. So albumin, you all know the ANSWER trial from Italy, led by Paolo Caraceni, and 431 patients with cirrhosis and uncomplicated ascites treated at least with significant doses of spironolactone, but not refractory ascites, were randomized to standard of care or to albumin that was given with a load followed by 40 grams every week. And you can see here that the use of repeated albumin infusions was associated with better survival. Not only better survival, but in the trial, they almost hit all potential endpoints: less SVP, less infections, less hepatic encephalopathy, less renal dysfunction. The only thing that was not different was bleeding. So very important study. Obviously, this will be, again, a huge use of resources. So I think before it's not giving a pill, it's bringing the patients every week for an albumin infusion. So we need more evidence before implementing this. This was followed by a double-blind randomized trial comparing midodrine TID with albumin every 15 days with a double placebo patients on the waiting list for liver transplant. They were much more advanced patients, and there were absolutely no difference in any outcome or in activation of neurohumoral systems. Not much. Very impressive that not much was seen despite using albumin every 15 days. We know that midodrine by itself is the potency as a vasoconstrictor is minimal in cirrhosis. But I wanted to introduce, to call your attention, because new things are coming. The Preciosa trial for 410 patients. The recruitment is complete, so we hope that we see the results soon. And this is albumin 1.5 grams per kilo every 10 days versus standard medical therapy in the compensated cirrhosis discharge from the hospital for a maximum of 12 months. The primary outcome is liver transplant or death. And the ALB trial that has a very interesting design that I will try to summarize in the next slide, and was just recently published a month ago or so in BMJ Open. So the design is available for everybody. So it tries to identify what patients might benefit from albumin. And the way for doing that is, again, indeed, with a randomized trial. So you cannot just treat patients with albumin and try to identify who benefit, because you don't have the counterfactual of what would have happened with these patients had they not received albumin. But randomized trial, you can do that. So it's a really beautiful design in which they take all patients, they give an albumin challenge to all those patients, and they analyze the potential responsiveness to albumin with a signature that they have developed based on biomarkers. And then they randomize patients to albumin or placebo in a blinded fashion, stratifying by these biomarkers of potential response, whether they are likely to be a responders or not likely to be a responders. And then that will allow to analyze whether the biomarker is good enough and whether there is heterogeneity of treatment response according to the biomarker. So very nice study. So the next is the use of SGLT1 inhibitors, and I wanted to call the attention of this paper by Dr. Singh that is very kindly in the audience, and that was presented in AASLD last year. I don't think it's yet published, and this was a randomized trial. Again, very difficult interpretation when you just give it in a non-randomized fashion, but these authors were bold enough to do a randomized trial. It was a pilot trial with dapagliflozin 10 versus placebo. The primary outcome was control of ascites at 6 months. And as you can see here, the control of ascites was much better with that of dapagliflozin. And this again emphasizes that flozins are excellent diuretics in contexts in which other diuretics do not work. For example, in end-stage kidney disease, they still work. So we could guess that in patients that do not respond to traditional diuretics in refractory ascites could respond to flozins. The issues with DAPA was that there were more infections, which is a consequence of its mechanism of action, and there was more AKI, 50% of AKI in DAPA group versus 15 in placebo group. But on the one hand, we know that this is something that happens with flozin. When you start dapagliflozin, there is always an increase in creatinine. So probably for these trials, we will need a different definition of AKI than the traditional definition of an increase in 0.3 of creatinine, because otherwise, almost every patient on dapagliflozin will end up having AKI. And I put this very old study from my old unit, from the liver unit in Barcelona, from many years ago, published in Lancet, in which they clearly show that when you treat patients with ascites and diuretics, there is an increase in creatinine. So this is more or less expected by the mechanism of action. There was no differences in the final eGFR. So by getting 50% of the patients with some degree of AKI, that did not result in a greater slope in the eGFR, mean arterial pressure melt, and no differences in mortality. So very interesting concept. This was a pilot study, but there are 4 clinical trials, randomized trials ongoing in patients with ascites, testing SGLT2 inhibitors. And the last medical advance that I wanted to put forward is this very nice Australian randomized trial that compare continuous infusion of terlipressin in patients with refractory ascites. And as I show in my first slide, the main mechanism leading to ascites, the original thing is splanchnic vasodilation. That is a consequence of portal hypertension. But splanchnic vasodilation is what has major consequences on the systemic circulation and kidney function. And you could hypothesize that if you are able to revert the splanchnic vasodilation, you will be able to deactivate the hormonal systems that lead to sodium retention and eventually renal vasoconstriction. So this was, again, this is published last month in Hepatology, was presented also last year in AASLD, and it was a crossover study of 12 weeks of continuous terlipressin infusion versus 12 weeks of observation with 30 participants. And the treatment periods were randomized. I put here how the system looks like. Obviously, the patient needs a central line, and they need this device that provides continuous infusion of terlipressin. So not, I will say it's really complicated. And the major endpoints were hand grip strength that clearly improved with, and this is a very substantial improvement in hand grip strength in the patients treated with continuous terlipressin infusion. And the ascites volume was also a significant decrease in comparison with the period on treatment with the period off treatment. 11 liters, very substantial, very impressive result. So, for me, this suggests that there is potential for treating refractory ascites. I don't think the system of central line pump will ever generalize. But from a conceptual point of view, I think this is extremely interesting because they are long-acting subcutaneous vasopressin analogs in development, and this provides a further rationale for that, and we might see a kind of a new approach for medically treating refractory ascites. So I switch over now from medical therapy to what I call advanced interventions. And I will start with when and how to tips. Two very important questions. So this is, again, an old meta-analysis, an aged already meta-analysis from almost 20 years ago, clearly showing that when you put a tips in patients with refractory or recurring ascites, there is a huge improvement with an odds ratio of 0.14. So this is an 86% decrease in the odds of having persisting ascites. So really, this is an impressive result of tips in the control of ascites. There are few medical therapies associated with this magnitude of effect. So this will be a perfect treatment for ascites, had it not caused complications. And we all know that hepatic encephalopathy is one of the most devastating complications for the patient, for the caregivers in cirrhosis. So TIPS is not perfect because it increases, it multiplies by 2 the risk of having, or more than 2 the risk of having significant hepatic encephalopathy. So very important concept with TIPS is that the effect of TIPS on ascites is not immediate. This is a paper from Florence Wong in Toronto many years ago showing that when you place a TIPS, it takes about a month to reach a negative sodium balance. And this was in very strict sodium restricted diet. So what I want to show here is that the effect is not immediate, and most of the times you need the help of diuretics to achieve control ascites, the control of ascites after placing a TIPS. So what TIPS mostly do is transform a refractory ascites in a diuretic treatable ascites. So this is a more up-to-date meta-analysis on showing the effect of mortality in all the trials that have been done for refractory ascites. They exclude the earlier study by Didier Lebrec. The latest trial that I'm going to talk about is also missing, but what I like from this is that it stratifies the patient, the trials that include both refractory and recidivant ascites patients, and this was defined in most cases as at least 3 paracentesis in a year, and there was a strong effect on mortality with a hazard ratio of 0.5 in a randomized trial. Hazard ratio in 0.5 in a randomized trial really is an impressive result. And patients, trials that include patients only with refractory ascites according to the definition by the International Ascites Club. And 2 out of 3 trials did not show any effect on mortality. 1 trial showed an impressive effect on mortality. So the results were very significant. So what I want to convey here is that probably the earlier you put the tips in the natural history of ascites and using that concept of recurring ascites, probably the better. And this was kind of confirmed in this is, to my knowledge, this is the latest trial of tips for refractory ascites done in France, multicenter, led by the group in Toulouse by Christophe Bourreau. And they use an inclusion criteria of recurrent tense ascites, requiring more than 2 large volume paracentesis in the previous 3 weeks. They randomized them to large volume paracentesis with albumin or to tips. And as you can see, the transplant-free survival was much better in the tips group. It's important to know what were the key inclusion criteria, key exclusion criteria. So patients with more than 6 large volume paracentesis within the previous months, within the previous 3 months were excluded. And this was because they thought that tips will be the standard of care in France. But it excludes the patients with more advanced sodium retention, circulatory dysfunction, patients that more than 70 years old, severe hepatic encephalopathy, and with severe liver failure, with a quite, so to exclude a patient, the patient had to be really bad, and a serum creatinine of more than 2.8. But when you really see the type of patients that they included with the baseline characteristics, the mean bilirubin was 1. So really, they did select patients with good liver function. Mean creatinine 1, mean INR 1.4, mean MELD score of 12. And another important concept is that 90% had alcohol-related cirrhosis, which we all know is a relatively reversible liver disease upon abstinence. And we are not sure whether these same results may apply to patients with, for example, NAFLD, that have probably the balance of risks taking into account that they might have HFpEF, they may have some degree of kidney dysfunction, they might be more prone for hepatic encephalopathy, the results might be different. But again, not very strict selection criteria. In real life, the trial really selected patients that had good liver function. And this is a plot that we put together a while ago on the mean bilirubin in the trial as a marker of how sick the patients in the trial were and the odds ratio for death with TIPS. And everything that is below the line is a benefit, a survival benefit with TIPS. Above the line, worse survival with TIPS. And as you see, the higher the bilirubin, the higher the chances that TIPS increase mortality. The lower the bilirubin, the higher the chances that TIPS improves survival. And these were trials with recurring ascites or refractory ascites. And this trial was in patients with refractory ascites, but with very strict liver and kidney function selection criteria. So again, they selected quite early patients. So similar concept, over the years, we have learned how to select patients for TIPS, even for randomized trials. How can we, again, going back to the risk of hepatic encephalopathy, any hepatic encephalopathy, 51% of patients with TIPS, the rate of severe encephalopathy in patients with refractory ascites is 39 in the TIPS arm. These are results from the randomized trial. So we have to look for mitigation strategies. Patient selection is key. Rifaximin starting before TIPS and the stent diameter. The patient selection, we have risk factors for predicting hepatic encephalopathy, prior hepatic encephalopathy, advanced liver function. The older the patient is, a patient over 70, I don't think is a candidate for for refractory ascites. Might be a candidate for variceal bleeding, in which is a life-saving procedure. Increased creatinine, hyponatremia, sarcopenia, and so these are all factors that might increase the risk of hepatic encephalopathy, and we have to take into account when selecting the patient. Not specifically related to hepatic encephalopathy, the patients have to have an excellent heart function and no pulmonary hypertension. What about pharmacological prevention of hepatic encephalopathy in patients undergoing TIPS? And we didn't have good data. We had a small pilot trial with rifaximin that was not positive, but we had this much larger trial, again, a multicenter trial led by Christophe Bourreau, assessing in a double-blind fashion in 186 patients. Most of the patients' TIPS was for refractory ascites, whether rifaximin could decrease the risk of hepatic encephalopathy starting 14 days before TIPS. And the main point was hepatic encephalopathy at 6 months, and the rate of hepatic encephalopathy was almost halved with rifaximin. It's difficult to get rifaximin for these patients because it's an expensive drug, at least in North America, not that expensive in Europe. And so getting it funded as a prophylactic treatment for TIPS might be difficult. The other concept I want to emphasize is on how the technical aspects of how we do TIPS. And when we do a TIPS for variceal bleeding, we want to get it right as soon as possible because the patient might be dying from ongoing bleeding. So the traditional criteria is that we have to decrease the portal pressure gradient to below 12, okay? And this is a recent study from the Barcelona group showing that when you have a final portal pressure gradient of less than 12 in patients treated with TIPS, the risk of subsequent complications of portal hypertension is very low. When the gradient is above 12, the risk of portal hypertension complications is higher. But the problem is that the lower the portal pressure gradient after TIPS, the higher the risk of hepatic encephalopathy. And you can see here that at 1 year after TIPS, the rate or the cumulative incidence of complications of portal hypertension is only 20%. So it's not bad. It's 80% success in those patients in which portal pressure gradient was of 12. And at 2 years is 33%. So again, it's a 70% success. Also, this is a study from the Journal Trubica group, in which what they found is that if patients have a less than 60% decrease in portal pressure gradient, they have a rate of persistent severe ascites 6 weeks after TIPS of 30%, as compared to only 20% if the gradient decreased less than 60%. But still, there is 70% success in patients that did not decrease, that did not achieve the target decrease in portal pressure gradient. So again, this is telling us that we have to be conservative in how much we decrease the gradient, especially in particular in patients that is never an emergent situation like refractory ascites. And this concept was explored initially in a pilot study comparing 8 millimeters stent group with 10 millimeters stent by Oliveira Riggio in Rome. And the problem with this trial is that it was prematurely stopped, but by the Data Safety Monitoring Board, after only including 24 patients with refractory ascites, because there was lower clinical efficacy in controlling ascites, and there was a similar risk of hepatic encephalopathy. But this, the main endpoint of the trial was the needle one paracentesis, and as I showed before, it takes time for tips to be effective. So just, considering failure after one paracentesis, probably it was not best way to analyze this trial. But the situation was different in this Chinese trial from the group of Dr. Han, in which they compare 8mm stents with 10mm stents in the prevention of recurrent bleeding, and there was half hepatic encephalopathy rate in patients with 8mm tips. And probably the study that opened our eyes to this problem was led by Filippo Schepis in Modena, a multi-center observational study in Italy, in which they clearly showed that the lower the stent diameter, which means that you achieve less reduction in the portal pressure gradient, the less the risk of hepatic encephalopathy. And they went as low as to 6mm diameter tips. But with low tips diameters, the risk of hepatic encephalopathy was markedly lower than the patients that had a wider diameter. So this has been facilitated with the new stents that have a variable diameter, and you can start at 8, go to 9, go to 10, and the main advantage of these variable diameter stents is that you dilate to 8 and they stay at 8. The other stents, the traditional 10 stents, you dilate to 8 and you never know whether it is going to go harder to a higher diameter. So all this background led to this proposal in the ALTA TIPS North American guidelines for TIPS, in which we clearly state that this for ascites is not an urgent procedure. The balance of benefit risk is different from the balance of benefit risk in acute variceal bleeding. Mitigation of hepatic encephalopathy should be given more weight than the immediate efficacy. And this was the proposal. The proposal was to ignore the pressure decrease in patients with refractory ascites. This is different from variceal bleeding. But and again, targeting a certain pressure, even if you do not achieve those targets, you will have a 70% efficacy at 2 years. So the idea was to start with the minimal diameter tips to 8mm in all. Whether this could be decreased, this is, the nominal minimal diameter of these stents is 8mm. So this is why we started at 8. But probably if they were diameters of 6, we will start at 6 and then increase the diameter. And if there's no response at 6 weeks, and you have to wait for 6 weeks, because otherwise you are not seeing the efficacy of the intervention, you dilate to 9, and if there is no response at 6 weeks, you dilate to 10. So it's very important to who we put a tips in and to how do we do these tips. Very, very important, because it might completely change the results in terms of hepatic encephalopathy. And in the last 5 minutes, I want to talk about the long-term abdominal drains. These are how they look like in a picture. This is how they look like in real life. They have a tunnelized part in the subcutaneous tissue. They are inserted into the peritoneum, and they have a valve which protects from any kind of reflux and markedly decreases the rate of potential infection. You cannot leave a traditional drain that does not have this system because that will be associated with a huge risk of infection. And then you put the bottles. This is a vacuum bottle, but many times you can do it just by gravity. And there were several pilot studies in palliative cirrhosis patients, And the main problem that was observed was a very high rate of infection as compared, because these strains were initially used in malignant ascites. So as compared to malignant ascites, cirrhosis ascites has very low protein and has a major risk of infection. And, we did our own pilot. We didn't have many infections. What we mainly observed was a huge improvement in the quality of life parameters related to abdominal symptoms. So we had this scale abdominal symptoms inventory. This is before placing the drain. And as you can see, in most patients, it was a major decrease. And many of them said, doctor, you don't know what is coming every week. I have to bring to the paracentesis clinic 2 different sets of trousers or pants, because I come with a belly like this, and then I leave a belly like that. So for me, the patient was telling this drain has supposed a real improvement in my quality of life. So there was a randomized control trial that was a feasibility trial from the UK group led by Dr. Verna, reduced feasibility study. They took 36 transplant eligible patients, randomized to the drain or to large forum paracentesis, and it had lower cost, lower time in hospital, more cellulitis, and not increased risk of peritonitis. And they clearly showed that these patients that have the drain, they need resources, home care, to help them in managing the drain. And this is now being evaluated. There is a very nice website from the Reduce 2 trial. 300 patients in the United Kingdom. They have the capacity of doing these large trials in patients with cirrhosis, and they wonder all of us on the organizative capacity. And we will hope that the primary outcome is health-related quality of life. This is not to improve survival. This is just to make the life of the patient better. And this UK group has published these guidelines and in frontline gastroenterology. I just want to emphasize the don'ts. And we don't do routine blood tests. We don't routinely check the cell count in these patients. We consider that if we do this to keep the patient out of the hospital, we are not going to start measuring all the time. Unless they have symptoms, we don't check the cell count. We never send cultures from the drains. And we just did the test in our pilot trial. If you send cultures, all the drains will have positive cultures for if you take fluid from the drain 1 week after it is inserted. So we never send cultures for the drain. And we try to summarize our experience in this website, cirrhosiscare.ca, which is the result of the talent of Punita Tandon, or organizing a fantastic resource to find anything you need to manage patients with cirrhosis. And among those, this is an example of orders that you need after placing one of these drains, and summarizing our experience with the complications. So my last slide, my take-home messages is that therapeutic paracentesis is a limited resource in most settings, so we have to ensure that ascites is really refractory. And we don't have to give up too soon with diuretic treatment. The future treatments, among those SGLT2 inhibitors, potentially long-acting vasoconstrictors, potentially albumin. Tips, I call this 2.0, that there is a refinement in patient selection, refinement in pharmacological prophylaxis of encephalopathy, and the technical choices, and these have improved the results of on how we do tips for refractory ascites. And therapeutic role of long-term abdominal drains beyond the use as just a palliative therapy is being assessed in a large randomized control trial. Thank you very much for your attention, and we will be happy to address any question.